Public dialogue and civic engagement are important. They play a role in improving the health and well-being of Texans across our great state. That's why Blue Cross and Blue Shield of Texas is proud to support Texas Tribune conversations like the one you're about to see.
Let me introduce our guests and let me provide a frame for this conversation, and we'll jump right in. We appreciate, again, their being here and your being here. On my left is Vivian Ho, who is the James A. Baker III Institute Chair in Health Economics at Rice University, Director of its Health Policy Forum, and a professor in its Department of Economics. Dr. Ho has served on the board of the Scientific Counselors for the National Center for Health and Statistics, and she's a founding board member of the American Society for Health Economists. Jonathan Macclements is Assistant Dean of Graduate Medical Education at the Dell Medical School at the University of Texas at Austin, which he tells me, I've actually gone out of order. I'm sorry. I was supposed to do Tom. Let me do Thomas Kim first. Thomas Kim, I didn't look up. That's the danger of not looking up. Thomas Kim is the Chief Medical Officer for Med2U, an Austin-based on-demand health services company offering both on-site and telehealth medical care. Trained in internal medicine and psychiatry, Dr. Kim has devoted his professional life to improving the quality of care for vulnerable populations while reducing the cost of care through the use of modern information technology. Now, Jonathan Macclements, Assistant Dean of Graduate Medical Education at the Dell Medical School at the University of Texas at Austin, which he tells me is going to be open in
39 days.
39 days, the new medical school at the UT Austin campus. A fellow of the American Academy of Family Physicians, he served as both the program director and chairman of family medicine at UT Health Northeast, as well as public health authority for Smith County. And then finally, Elena Marks is president and CEO of the Episcopal Health Foundation, in that capacity overseeing a $1 billion nonprofit engaged in community health transformation in Texas. She's also a non-resident fellow in health policy at the Baker Institute of Public Policy at Rice. Previously, she served as director of health and environmental policy for the city of Houston. Please give our distinguished panelists a big hand. Happy to have them here. So as a frame for this conversation, I want to observe that typically when we gather in a setting like this, what we talk about is the uninsured population in Texas. It's what everybody talks about, and it's what we ought to be talking about. This is a problem that we've had in Texas for some time, the fact that we have the most people in raw numbers and as a percentage of our population without health insurance. And that percentage has gone down over the now 6+ years that the Affordable Care Act has been in law, thanks in no part to the state, which has wanted nothing to do with it. But despite that, in the ACA's lifetime, the percentage of our uninsured population first went down recently to below 20% for the first time, and now, as of the numbers that came out last Friday, we're down to 16.8% of our population without health insurance, and the national population without health insurance is now in single digits for the first time. All that is great. We tend to focus on access to coverage, and the question that is the premise for today's conversation is really, is that the wrong conversation, or is there another conversation, and that is access to care? Should we be talking about not whether we have enough people in the state with health insurance, but are there enough medical providers to treat the fast-growing, dynamically changing population of the state? Here are some statistics as a frame for our conversation and for the audience's benefit. Texas now is in the bottom 20, and has been for some time, in the bottom 20% among the states in the number of physicians per 100,000 residents. In fact, the last statistics I saw had us at 41st out of 50. We may, in fact, be below that. We have somewhere in the vicinity of 185 doctors per 100,000 residents. The national average is actually 225 doctors per 100,000 residents. 1 in 7 of the 254 Texas counties have no doctors whatsoever. 1 in 7 of our Texas counties have no doctors of any kind. 80 have fewer than 5 doctors for the entire county. And we have more than half of our counties in Texas with no OBGYN, with no general psychiatrist, or no general surgeon. And 126 of our 254 counties have been designated as health professional shortage areas by the U.S. Department of Health and Human Services. So there's really no way to conclude, Dr. Kim, walking away from those stats, that we have a problem. This is not just, we're only telling you the bad news. Would you agree?
I would, emphatically. I'm
First off, I'd like to thank Evan and the Tribune to invite me to join this illustrious panel. I seem to be the odd man out. When I finished the 26th grade about 10 years ago, I set forth bushwhacking a path on trying to figure out how to actually take care of patients. It was incredibly unsatisfying. It was extraordinarily difficult. And through serendipity, I found myself picking up a moonlighting gig taking care of incarcerated juveniles in the state of Louisiana. My eyes were open and I was like, this is amazing.
Yeah.
But then shortly thereafter, my wife had to do a fellowship in Georgia. And of course, I wanted to move with her. And my question to LSU at the time was, can I continue to take care of these kids? Because I had been doing it, telehealth from New Orleans out into the middle of nowhere. And they looked at me like I was insane. The bottom line being, and I really credit the Jesuits, I don't know if it's a blessing or a curse, but like the Tribune, I always seek the proper form of a question. Today's event is entitled, Do We Have Enough Doctors? I'm not entirely sure that is the right question.
Okay.
I would like to know how well are we using doctors at present? And I think the answer to that is poorly.
Right.
Both in terms of distribution. We typically congregate in urban areas where the same 6 guys are chasing a nickel, which is a problem. And
well, in fact, let me say to Dr. Kim, so 57% of our doctors are in the 5 big counties in Texas,
exactly
Bear,
right.
Travis, Dallas, Harris, and Tarrant, but only 44% of the population is there. So we're actually over-serving in the urban areas and under-serving in the non-urban areas, to your point.
That's exactly right.
Right.
And this is something that I think that we need to address initially prior to adding more people to the roles. Because historically, we've tried to do a number of things on a broad scale in policy and through regulation to try and spread us out a little bit through loan repayments, through all sorts of incentive programs, and they are effective to a point, but as Evan accurately pointed out, we're still doing a terrible job taking care of each other.
Elena, Ms. Marks, Dr. Kim is focused on vulnerable populations at the Episcopal Health Foundation, so are you.
Yes.
I appreciate what he's saying, that maybe the question is not, do we have enough doctors? I kind of think it is, and it's also, rather than instead of, are we using the doctors we have the right way? But in vulnerable communities, specifically, this is a big issue, right? It's not so much whether we have enough, but it's also, are we deploying our resources effectively?
And I would look beyond doctors. I think that the scope of practice issues around nurse practitioners and other mid-levels
it's
could
really
be
medical
increased.
professionals.
It's really medical professionals, and there's a lot of work that could be done by non-physicians. And when I look at the physician shortage, based on all of those statistics, I look at it from the primary care perspective because that's really where the shortage is.
Right.
I know we have shortages in various
Well, in fact,
of
the
the
primary
medical
care shortage
specialties.
is actually even greater than the overall shortage.
It's much greater.
Much greater.
It's much greater. And if you really want to improve the health of vulnerable populations and you're working at the community level, your primary care availability is much more important than the specialty availability because they are the link to more upstream work and to really solving the root causes of health problems that might not originate in the first place. And that's something that happens in a primary care setting led by physicians, but really in a multidisciplinary team where most of the people are not physicians. And I think we don't do a good enough job of using non-physicians to do a lot of health services work.
What do you think the obstacle is to non-physicians being part of this conversation?
I think some of that problem is physicians themselves who work pretty hard to restrict scope of practice for non-physicians or non-MDs. And I think some of it has to do with payment structures where we pay doctors to do certain things and providers are not necessarily compensated if a non-physician performs the same function.
Well, you teed up my pivot to Dr. Ho, who is a health economist by background and by disposition. You know, it's not as if, Dr. Ho, there's not demand. If we talk about all, population of the state was 20 million in 2000, it's 27 million today, it's going to 54 million by 2050. We have all these people with all these health challenges, and you would think that demand would ultimately result in supply, but that doesn't seem to be what's happening.
Well, training physicians is extremely expensive. So it's very costly. The state pays a large portion of the subsidies for training of medical students and residents. And unfortunately, for example, if you look at a place like Baylor, most of the medical students who graduate, by the time that they finish, their debt is so high that they then choose to go into a specialty with a higher income later on. Right. So the worst compensated physicians are the primary care physicians.
That
and they
gets
choose
to
not
Elena's
to do that.
point that we
Exactly.
have a primary care shortage in part because it's more attractive and more lucrative to go into a specialty.
Yes.
Absolutely. So, you know, that's the things that the physicians choose to do. A lot of the private insurance is fee for service. And so the more you do, the more you get paid. But, you know, these physicians, because of the way we set up our reimbursements, they want to locate in the urban areas and not in the rural outlying areas where we really need them to be practicing.
Do we do a sufficient job? I know the answer to this. I'm sort of teeing this up like a big fat softball pitch, Dr. Ho. Do we do a sufficient job of reimbursing our doctors who take care of our most vulnerable citizens, or are we behind the curve on that, and that may be pushing some people out of state or at least out of the profession?
Yes, absolutely not. You know, we're with the way the reimbursement is set. I said it's pay for quantity, not pay for performance, and so it's very lucrative to perform high-tech procedures in urban areas to well-insured patients. It's not as lucrative to set up shop in a rural area where a lot of people have lower incomes. Their insurance is not as generous. They, you know, they may be uninsured.
Yeah.
So it's, you know, it's unfortunate. There's parts of the federal government that will give subsidies and they'll give you breaks on your medical loans if you go there and practice for a couple years after you've finished all your training. But you know, I have a real problem with the way we adjust for reimbursements within even the Medicare system. There are higher reimbursement rates for places that have higher costs of living. Well, what is that going to do? It's going to make your physician say, oh, you know, I can practice in San Francisco, I can practice in New York City, and I'll get paid for the cost.
Yeah.
And then if it's lower cost in the various parts of, you know, rural Texas, you're going to get a lower income.
Right. There's not a very high incentive to be in Alvarado or in Mejia as a doc. Training of docs came up, Dr. Macclements, and so I looked to you. You're obviously now in the business of training the next generation of docs, and this is a consequential thing. This is the first, as I understand it, this is the first new medical school on a research university campus in how many years?
50 years.
In 50 years.
Yes, sir.
So we have the Dell Medical School, which is seeking to, with some help from the legislature,
Yes.
trying to get back in the business of training docs who would be trained here and then hopefully would stay here. You want to be part of the solution to this problem.
Oh, absolutely. And,
Yeah.
you know, Dean Clay Johnston is bringing a team together actually to identify these issues. He's looking at population redesign and bringing in top-notch colleagues who are actually looking at the financial dynamics of this.
Yeah, and this has been a problem, as I understand it, that we have been sending our best kids out of state to be trained.
Correct.
And you tend to stay in the vicinity of where you do your medical training, and therefore we're losing a lot of, it's like a brain drain.
Correct.
Right, we're losing a lot of good.
Right, and so to that
possible
point,
bodies.
at this stage, we only retain about 49% of all our medical students. So the Texas Medical Association last year made the argument to the legislature how important it was to try and hit a 1-to-1 ratio, excuse me, so the number of medical students that we're training in the state actually stay, because for that reason we know that when a medical student leaves the state and goes and gets their residency training outside of the state, the chance of them coming back is significantly diminished.
Right.
So for that reason, we were delighted in the medical education side when Senate Bill 18 was passed, that did allocate more monies to graduate medical education expansion so that we could try and address those needs. But to your point, this is a very complicated topic. You know, the Institute of Medicine came out with a report that left a number of our colleagues questioning, because the Institute of Medicine actually asked the same question that you're asking, is do we have sufficient physicians? And Dr. Berwick's report essentially focused on the fact that a lot of it has to do with geographic location. Are we training the right physicians, and can we be using more mid-level providers? That was answered in response by a number of other organizations who even questioned that, making the argument that we may have a shortage of about 35 to 40,000 primary care and the same amount of specialist shortage in the next 10 to 15 years. So
Right.
I had served as the chair of the Physician Distribution and Healthcare Access educational component of the TMA, and this may surprise a number of people in the room, but actually were we to place physicians in about 500 positions in the state of Texas right now, we could eradicate medically underserved areas and health professional shortage
If
areas.
you just basically move the chairs around.
Correct.
So why don't you do it?
That's an excellent question. I think, I think to the discussion, you know, a number of our medical students come out with about $200,000 to $250,000 worth of debt. They find it attractive to seek specialties that will help pay off that debt.
Right.
But there is certainly, as far as the medical schools are concerned, there is more of a focus on primary care, so that we can actually address the needs of Texans.
Right. And so we're clear on the magnitude of the impact that you'll have. You told me you had 4,000 applicants for the first class.
Yes.
At the Dell Medical School, and you'll have an entering class this fall
Of 50.
Of 50. So you've had to turn away. I don't make it sound like you were mean about it, but you had the capacity for 50. You turned away, obviously, quite a significant number of people who would have liked to come.
Yes, because there is an interest in the community. You know, the
Right.
student would like to. We'd like to think it's because we're very competitive that we've
Right.
attracted so many.
Yeah.
But yes.
To this question of geography, Dr. Kim, you talked about the prospect of telemedicine being an answer here.
Mm-hmm.
We have a lot of rural areas that are underserved. We have a lot of non-rural areas that are just growing really quickly, and we can't keep up with the demand for it. What are the dynamics of telemedicine or telehealth being part of this conversation in terms of addressing some of the things you've heard?
I have so many comments. So I think that we're being very faithful to portraying the bad and the ugly. The good about Texas is that as a state, we've attracted 40,000 physicians since 2003 being notable for tort reform being passed.
Right.
So
when tort reform was passed by the state, and it passed 52%, we were told that the floodgates would open and that doctors would stream into the state of Texas.
And in fact, they have. And in fact, the last 5 years have shown the most accelerated pace of doctors coming into it. Now, that's in addition to tort reform, and has to do with the fact that we have a strong economy, that we have good quality of living, and a variety of other things. But to the issue of why don't we move the chairs around, the short answer is human behavior. It doesn't matter whether you're a physician or an advanced practice nurse or a physician assistant or any of those things. When given the choices, as Dr. Ho pointed out, I want to live somewhere where I can get a good meal and a show and meet interesting and dynamic people.
Right.
And the prospect of going to these places that desperately, desperately need us is simply not as attractive. And
It's a lifestyle choice.
We're willing to live. I mean, this is what it is to be human. We're driven by, sort
Right.
of the positives and the negatives. So for me, the reason that I've gone on this no longer so crazy sort of path out on a branch is that I am able to care for exactly the people that I wish to, and am able to construct care solutions, including team-based approaches using nurse practitioners in my current venture, to push out to places that desperately need it while living in what I believe the best place on earth, Austin, Texas.
So you can hashtag ad. So you can make the argument that the care because you know what the pushback against this has been is that the quality of care is simply not going to be as good if you're on a screen somewhere, and they're back where they live. You can make the argument that the quality of care is adequate enough, if not as good, in a remote way.
Once again, allow me to reframe the question.
Go ahead. We might switch chairs before the hour is up. Actually. Go
Through the history of telehealth, which some argue began with the ancient Greeks sending smoke signals from mountaintop to mountaintop, folks have been making this sort of question about comparable efficacy between traditional and telehealth services. It's the wrong question. When you're confronted with the actual real case alternative of nothing, how can you not make the bid for a telehealth solution?
Right.
That being said, having done this for about 10 years now, I can say that I actually deliver, in some ways, a higher quality of care when it comes to timeliness. When you can put the right provider in the right situation at the right time, you will save money. You will give better care, and globally, everybody will be more satisfied with the proposition rather than 6-hour waits in a clinic after a 3-hour drive, getting paid $2. Yeah.
It's intriguing, Ms. Marks, to hear Dr. Kim talk about this because, in fact, the parts of the state, I mentioned the growth in the population, the parts of the state where the population is growing the fastest and changing the most dynamically are now and have been for some time in the Rio Grande Valley. I mean, for all the urban growth that we've seen in Texas and We had a new set of statistics yesterday come out or this morning from the Census Bureau that Georgetown, Texas, New Braunfels, Texas, and Frisco, Texas, none of those in the Rio Grande Valley, are 3 of the 4 fastest growing cities in the whole country over the last year. But the Rio Grande Valley is really seeing dynamic growth and dynamic change. Is that a sufficient answer in a population? I mean, again, you're focused on underserved populations. These majority Hispanic populations, very heavily uninsured populations, where maybe the history of access to care has not been as great. Is technology going to be a solution in communities like those?
I think it's a really important part. It may not solve the entire problem, but I think the more that we can try to use technology, the better off we'll be, and it won't always be perfect. The Texas Medical Board has restricted the use of telehealth, and they've been enjoined by a court so that it's opened up a little more broadly. But again, our physicians who kind of control the practice and aren't able to meet all of the needs need to be more open-minded about trying to allow others to meet the needs, and having an open telehealth policy the way many other states do is an answer to that.
Do you worry, Ms. Marks, the populations we're talking about are often populations that don't have the same access to technology as populations in the big city do? We know that 50% of Hispanic households don't have access to broadband. 44% of African American households don't have access to broadband compared to 28% of white households. If we're going to deliver a solution to this problem of access to care through technology, do we have a broadband divide problem that's going to get in our way as an obstacle?
We do, but telehealth doesn't always have to happen at the home. I know that yours is someone can call and access you directly, but telehealth is a really great solution to complement what's already going on in a social service or other healthcare setting, so that you can expand access, so that it's not a person who has to sit in their own home where they don't have broadband access and do it, but it can be facilitated through, we're funding in some rural areas right now telehealth, providing primary care in schools and rural school districts. And the school nurse is the facilitator on the other end. So it's not some kid or their parent having to figure this out. But we have primary care physicians who are working with school nurses to deliver that in a setting that is amenable to the patient, has the technology, and allows access that simply wasn't going to happen without it.
Forgive my interjection. I can't let your prior comment pass. You mentioned that Texas is restrictive to telehealth. It's simply not true. A year ago, last December, the TMB issued what they called an emergency rule, which effectively was a reiteration, just a reaffirmation of how to conduct telehealth in the state of Texas. As somebody who's been doing this for a couple of years, Texas actually leans on the side of being more permissive, more embracing of telehealth. And I won't go into the details as far as how this misunderstanding that continues to be perpetuated through the media and journals. Texas has been a leader in telehealth, continues to be a leader. But what they're attempting to do is to create regulatory guidance and guardrails towards doing this correctly. Because there are dangers afoot. And to your point of maybe it's not the silver bullet for all situations, because I recognize that, I want to ensure that folks who get into my space do it appropriately.
Dr. Macclements, what you're doing at the medical school is because you're building a medical school from scratch in the digital age, you are in a different way trying to use technology to get at the training of new doctors and the delivery of care. Can you talk a bit about that?
So we're looking at healthcare redesign, and the dean has brought in world-class experts to look at how we are providing healthcare. So there is a new building going up looking at the delivery systems in terms of integrated practice units within the building itself, and telemedicine is certainly part of the discussion under the Population Health Department with Bill Tierney. And to your point as well, as far as the TMA is concerned, that is one of the areas of interest that we're looking at in how we can remove this bottleneck of access to care. Is telemedicine is certainly part of that.
Dr. Ho, the economics of practicing in a state like Texas do or do not incentivize people to come here. So as an add-on to this conversation, is this a good place to, generally speaking, is this a good place to do this job?
For physicians to come and practice? I think it's a terrific place to come in the urban areas and, you know, the largest 5 counties you talked about.
Right.
I think it's more of a struggle in the rural areas where, you know, the amenities that people are used to aren't there.
But the same things that attract other business and other professions, other industries to Texas, and that we've bragged about so loudly over the last 15 years, low taxes, predictable regulation, no personal income tax in the state. Presumably those are all conditions that would give reason for people to want to work here in medical professions as well as other professions.
Yeah. Yes, absolutely. So you know, the thing, you know, we struggle with this in terms, Rice trying to recruit professors. There are people who've never been to Texas before and have some sort of bizarre conception of what this state looks like, and so they say, no, I'm just not even going to consider Texas because they, you know,
right.
they all walk around with cowboy hats and you know, have to wear boots to work and things like that. The other thing, you know, let me go a bit socialist here, but so
it's in fashion. Go ahead.
So telemedicine can do a lot of things to help.
Yeah.
But the other thing is there are people from these communities who like to live there, and I think we have to be more aggressive in terms of promoting sort of medical education and finding the talented people in those areas to train, and then they want to go back home.
Right.
And I'm not sure that is discussed as much when you sort of go out and recruit a class for a medical school.
Do you think, Dr. Ho, and I would also ask Dr. Macclements to weigh in on this, should there be some kind of an incentive to try to attract medical talent to these underserved areas, rather like a Teach
There
for
is.
America? Is there such a program right now?
It exists now. I mean,
Right,
there's
it
several
does.
programs.
Talk about that, because that would seem to me, I mean, if we have to put our thumbs on the scale to get people to serve in real time,
You know this better than
talk about that.
So, as a result of funding that was taken from tobacco monies that was reassigned, several years ago, several programs were started up so that residents could go out into the rural environment and have their their student loans repaid. It worked well initially, but unfortunately, it was dependent on the legislative cycle as to whether or not there was funding. So the challenge for me personally as a program director, having sent a number of my family medicine residents out into the community, into West Texas,
Right.
is that they got established in the community, to your point about economics, that, you know, if they had more than 40% of their practice was Medicaid, they struggled to keep the doors open. But these were young individuals who were absolutely committed to taking care of their communities. And a number of them, after about 3 or 4 years, left the communities because they were financially unable to absolutely
stay.
unable
But
to
of course,
stand
you're
it.
talking about a program that relied on the legislature for funding.
Well, but then the good news was, as a result of education of the legislature, what happened is they then they ensured that it was a 4-year payment and was not dependent on the legislative cycle, and that in itself has made a huge difference. And that
Right.
I haven't seen the recent numbers, but the last time I saw it, it was very well received by those going out into the community.
Yeah.
So a number of, and it was open to primary care, family medicine, internal medicine, pediatrics, and it also expanded off into the dental profession as well.
Dr. Ho, I wanted to ask you as well about the changing nature of the population. So as Texas moves from being, as it was some 10 years ago, a majority Anglo population with health challenges and opportunities from the medical profession standpoint that might have been very particular to that population, to where we are now, which is majority minority, to where we will be in 2040, which is, as your colleague Steve Murdoch has predicted, I believe, 55% Hispanic population in the state of Texas, 32% Anglo, and the percentage of 65 and older residents of the state of Texas doubling between now and, say, 25 years out. How will that change this conversation from your perspective?
Well, yeah. So there's this gradual aging of the population, and then the change in the demographics, and we know that a good portion of high quality health care is cultural. So that you know, whether we get more physicians from these particular backgrounds or train physicians more in terms of cultural sensitivity, so they can pick up on, you know, when do patients comply with recommendations, when do they not understand what a complex chemotherapy regimen is, and what can they do about it. So that's all going to become a more important part of training and things like that. What I find so fascinating about all these studies about do we have enough physicians, primary care physicians and specialists, is it's just this sort of thoughtless sort of matching of, okay, so usually we have X number of physicians per 1,000 population, and it's so unsophisticated compared to what economists do in terms of production functions. When we look at the production function for building an airplane or building a car or something like that, and people aren't taking account of that. They're not taking account. Suppose we really wanted to have the most, sort of efficient method of caring for the best, the largest number of patients with high quality. What factors go into that? And I haven't seen a single study like that.
Yeah.
And particularly with all the changes in technology, what happens when you add on telehealth? What happens when you move from fee-for-service to HMO and move to an accountable care organization? There's all this stuff that's going on and no one's looking at it.
Well, I'm intrigued by the idea that if you're going to do these statistics, if you're going to use these statistics as the basis for this conversation, not all 100,000 residents are equal.
Right.
And
Yeah.
not all X number of doctors contributing to that solution are themselves equal, right? So it's not really an apples to apples situation.
Right, and yeah, that too. But look at, you're right. And then sort of course, the characteristics of the population matter absolutely in that. But the level of sophistication of the studies is well below what we could be doing, which would actually give us some insights in terms of future planning.
Right. Ms. Marks, I gave Dr. Ho a big fat softball earlier. Let me give you a big fat softball now.
Oh, good.
So Texas has been resistant to the Affordable Care Act since its implementation, and as a result, its uninsured population at a minimum has declined at a slower rate than in states that have embraced.
Yes.
And we can have a political argument about this, and we could debate are premiums proper or improper, or costs going up or going down. At the end of the day, we know that our population's uninsured, or the percentage of our population that's uninsured has in fact declined. Would we be having a different conversation 6 years in about whether we have enough medical professionals available to treat our population if we had embraced the Affordable Care Act?
I think we'd be having that conversation in part because so many Texans are insured and would be if we'd expanded Medicaid through Medicaid, and the Medicaid reimbursement rates, which are controlled by the state, are very low.
And let's talk about that for a second. So the Medicaid reimbursement rate was a topic of conversation in the last legislative session. The current Medicaid reimbursement rate, I believe, is 64 cents on the dollar versus the Medicare. 64% of Medicare, is that what it was? And the Senate
varies.
Close, and the Senate had wanted it to remain where it was. The House had wanted to raise it to 100% of Medicare, and ultimately the budget that was approved by the legislature stayed with the lower reimbursement rate. I have that mostly correct, right?
For me,
Yeah.
about 45 cents on the dollar.
You're even getting lower than that. So that the state's component of this is a material factor.
Yes,
Right.
and even though we are now delivering almost all Medicaid through managed care organizations, the state still sets the amount that it gives each managed care organization, and while they are free to negotiate with their providers, they've only got this much money within which to negotiate.
And as a result of that, direct or indirect, we have a very low percentage of doctors taking on new Medicaid patients now. I think it's 34%. It's some historic low, I believe, at the moment.
Taking on new Medicaid patients. And while I don't think that's a reason not to expand Medicaid, I mean, you don't say, oh, well, there's already a line, so don't let more people get in line. It doesn't address the fact that unless and until we are able to pay doctors who serve those patients a little bit more, we're going to continue to have the same problem of not having enough doctors who are willing to see those patients. And I would say that the discrepancy between the number of physicians we have per capita, regardless of how refined that is largely due to the fact that we have high rates of uninsured, and to the extent we have a large population on Medicaid, because even though they're mostly kids and pregnant women, we have a poor population. And so when you have that many people who are no pays and low pays, you're not going to attract a lot of physicians.
It's a lifestyle, even if you could had fantastic restaurants in these rural areas and, Netflix and chill and all that, you create a fantastic environment for people to be. At the end of the day, it's going to come down to the factors that you're talking about that may keep doctors from locating. In fact, this was sort of, in some ways, the basis for this conversation. Ms. Marks, was the idea that even if you insured everybody tomorrow, if all of a sudden state leadership woke up, as apparently Oklahoma to the north of us may be doing right now, and go, you know, actually on second thought, maybe we should expand Medicaid and accept all this money. In fact, if we expanded Medicaid tomorrow and all of a sudden everybody had insurance, there's an open question as to whether we'd have enough people to take those patients, right?
To take all of those patients
All those
to
new
do every
patients on
single
yeah.
thing. But
Yeah.
I think there is certainly room in the system for more people, even people who are insured by Medicaid, because the plans are still able to attract sufficient providers. There's a limit to that.
Yes.
But I don't think we've reached it yet.
We have not reached
but
it.
at some point, we will. And the only way to address that is for the reimbursement rates to be raised. And that means the MCOs have to get more money so that they can negotiate, even when they're negotiating very creatively bundled payments and some really interesting upstream work. You know, if it costs $10,000 to take care of someone and you're given $5,000, there's only so much you can do.
Right. Dr. Macclements, you wanted to...
So I just also wanted to make the point, though, that as physicians, this is something that we're incredibly sensitive to. We don't see our patients as dollar signs.
Yeah.
It's within the academic environment and within the community of physicians, we want to take care of our patients. It simply reaches a point of financial dynamics and what is doable. You know, we talked about this earlier as to we could resolve the issues if we had just 500 well-placed physicians. The challenge is, though, that a physician isn't just a widget that we can just put into that spot.
Right.
The human factor comes into it. You know, the issues of, you know, the spouse, does the spouse like the environment that they're living in? What about the children? Where do they get educated?
Yeah.
So there's a lot of discussion that we may have to reflect on that happens in the rest of the world where there's public service that occurs.
Well,
so
this gets to Ms. Mark's point. I mean, I'm thinking about you training the next generation of doctors and wondering, although I think I know the answer, how many of the people who are applying to medical schools these days are thinking, I want to go to medical school so that I can perform work at that level of public service? How many of them are thinking, I'm doing this essentially to come out and then put myself in these very challenging circumstances? Or how many of them are thinking, you know, I'm jumping on the last car of the gravy train?
So the reason why I'm so passionate about training the next generation, there is nothing better than going to work every single day and seeing the enthusiasm of the younger generation.
Yeah.
They have the greatest ideas on how to solve the world's problems. You know, this current generation has a fascination with global health and wants to go out and solve the world's problems. And somewhere along the line, something changes, and that where does that cynicism come in, and how can we prevent that occurring is something that we as educators are focusing on.
Yeah.
And part of it is really rethinking how we offer healthcare services. But no, I can absolutely assure you the next generation is very enthusiastic.
So they are plugged into this.
Oh, absolutely.
So let me, before we go to questions from the audience, let me ask each of you, I'm going to give you briefly the powers of the monarchy. You have now the ability to move any legislator or any policy thing just with the wave of your hand. If there are one or two things that you think we need to be thinking about as a state or as a medical profession or as a political system that would advance this conversation so that the next time we sit here we won't be talking about a shortage or a concern about the allocation of the resources we have, but we'll be en route to solving the problem, what would that be? Dr. Hope?
I think we need to shift the incentives in the training system towards more primary care physicians, making it cheaper for a student to go and go to medical school, but to only finish in primary care, not to go on to specialties. We give an extra subsidy because those are the people who are going to be most valuable in terms of delivering, you know, quality health care for the most Texans who need it.
Yeah. Okay. Dr. Kim?
If I were czar of the universe, I would probably...
I said monarch. You went to czar. I'm going to just leave that. I'm going to observe that you changed that on your own.
Yes, sir. If I were czar of the universe, I would, if not in practice, in principle, create a single pathway reimbursement system so that the rules were agreed upon by everybody rather than having to navigate this gauntlet. And I would remove the geographic restrictions to allow me to do what I do in anywhere that requires assistance. Myself and others who are slowly being skilled in this in telehealth can
and so I'm clear on this. When you refer to geographic restrictions, where are you restricted from doing what you do?
Uncle Sam will only pay me to service folks in health provider shortage areas and non-metropolitan statistical areas, so rural America. Fortunately, we've made some progress in the sense that in the state of Texas, Medicaid removed recently, a couple of years ago, that restriction.
And fortunately, as I say, or unfortunately, we have 126 health professional shortage areas, so you've got fertile ground.
Correct. So simply just parity and a simpler pathway to getting paid, not a lot, just not so complicated. The burden on all providers on just navigating the economics of healthcare delivery and sustaining a practice is incredibly difficult, and that burden is what's driving most of these folks out of the system.
Dr. Macclements, you have had some kind of benevolence visited upon you in the form of the legislature providing more money for GME in the last legislative session. I assume you all are going to go back to the well next time.
Oh, absolutely.
Yeah.
And to your question, you know, those of us in education are acutely aware of, we don't want the dumbing down of medicine as we redefine everything. And so using various other resources is challenging to us. So what we still want to train the quality physician that we currently train. I would have it, we train some of the best physicians in the world.
Right.
The challenge for us in education is how do we align the resources to meet the needs of the educators so that we can put our learner in the environment they need to be in. So to that point, the way finances work at the moment is through, there's money supporting us on the graduate medical education side that comes from CMS, which has been capped with the Balanced Budgetary Act of 1996. And to your audience, what that means is that the funding source that was available for graduate medical education back in 1996 is what is hospital is currently capped at, which means that any
1996 levels.
1996 levels. So if a hospital reported on their cost report in 1996 that they had 100 residents, that means currently the way the funding source flows through the federal government is to that hospital for a maximum of 100. Despite the fact that we still have this need in the community for expansion, we're still capped at those numbers.
And despite the fact that the population of the state
is
has
increasing.
Grown since 1996 by some, you know, I don't know, whatever, 40%?
Right.
Yeah.
And to your point, we're still ranked number 41, 42 in the nation, despite the fact that we've had the highest influx of physicians due to you know, lifestyle issues, tort reform, etc.
So this is a federalism argument, basically. We need the federal government to get out of our business, and we need to regard the 50 states as all individual and different and...
Well, so no, not necessarily. So just that we can, so that we have an honest discussion of how the money flows for education. And to your previous point is, so those of us in education are delighted with Senate Bill 18 because as a direct result of that, we have additional resources on the graduate medical education side to try and hit this 1-to-1 ratio and retain physicians.
But you will be hoping to build on that in the next.
Yes, and the reason is simply this, is that once you've expanded and you've had those resources, if those resources go away, the only way to continue funding that position at about $100,000 to $125,000 per resident per year for their salaries in education is you have to find novel ways to generate it either through clinical activity or philanthropy.
Well.
So it's, you know, it's either from federal resources, state resources, clinical productivity or philanthropy.
And speaking of philanthropy, we happen to have philanthropy sitting right here.
Great.
We're funder
And
of Dell.
fantastic.
And one of the things, as you know, Ms. Marks, that's happened over the last number of years is that as healthcare costs of the state have risen and the contribution of the state to not only healthcare but essentially every area of life in the state has necessarily had to go down, philanthropy has had to step in and solve some of the problems that the public sector once upon a time solved itself. So you are more often now part of this conversation. Right.
We are, but our job is not to do what the government ought to be doing. Our job is to allow for experimentation and testing and some supplementation, but we don't have the resources, nor is it our role to make up for the government's refusal to take care of its people.
So if you waved your wand, one thing you would do is get the government back in the business of doing the things that it ought to be doing, I expect.
To recognize that doing the things that it thinks it's doing cost a lot more money than they're willing to acknowledge.
Right. What else would you think would be a significant contribution to resolving this challenge we're talking about up here today?
So I have high hopes, I hope not false hopes, but for the payment reform that is going on nationally and is trickling from some of the very most expensive processes all the way down to primary care and out. And if we can get to a point where we're actually paying providers, not just physicians, but providers of health services for improving the health of the people they serve and the communities they serve, I think you will see a lot of shifting in what people do. Right now they're paid to deliver certain specific services, and so they do. And if you pay people to deliver health outcomes as opposed to health services, I think you will see behaviors change, and you'll see where money is spent and how provider entities think about capturing revenue very differently than they do today.
Let me just, we'll ask people to line up if you have questions behind this microphone here. Let me ask Dr. Kim, to Ms. Marks's point, you're the one provider up on the stage. Do you have a problem? Well, I mean, Dr. Macclements is a provider on some level, but I'm sure you're like actually seeing patients right now. Do you have a problem with shifting to a system in which we reward outcomes as opposed to inputs?
Absolutely not. I believe I'm on page 36 of the 962-page document that Uncle Sam just released on MACRA, and it's keeping me up at nights. The broad stroke of it is that it's going to be a rocky road towards this value-based system. I'm enthusiastically in support of it. I'm not exactly sure which of the two tracks are going to be better for me.
But generally speaking, outputs as opposed to inputs is good with
Absolutely.
you. And is that the case across the profession?
No, because to Ms. Mark's points, we are rewarded for pulling the lever. There are many people, typically folks older than I am, who are very good at it. And again, back to first principles human behavior. When you're really good at something, you're going to continue to do it.
You stay with it, right?
And so perhaps we just need patience and persistence towards waiting for these millennials to really start, assuming some of the levers of power and make different choices. I know just last week, while traveling, I avoided a hospitalization for one of my prison kids simply by talking to him in the right moment. He was upset, he was making self-harm gestures. I knew he wasn't overtly suicidal, and when I was given an opportunity to speak with him, he pulled it together. That cost all of us very little, and that avoided hospitalization at present is not in any way tracked. And so when you actually look at what we're able to verify and document, I simply had a couple of extra encounters compared to my other colleagues, but my encounters are very different. And as a result, if we can actually wrap our arms around how do we check the box on giving value care, which is a very complicated proposition, then I'm optimistic. I am perhaps the most optimistic guy I know when I go around talking about the medical apocalypse.
Good. Although you did just end with the words medical apocalypse, which doesn't make me feel very optimistic. Let's start with questions. Hello, Mr. Jones, how are you?
Hi, my name's Hank Jones. I'm an information technology lawyer and business person who recently moved from Austin to Houston. On the topic of telemedicine and Texas, particularly as it compares to other states, on May 21st, the federal judge in Austin found, after an open trial and briefing both sides, the Texas Medical Board had actually passed rules quickly in a non-traditional process only after losing a state litigation at the trial and the appellate level, at least on procedural levels, and found that the new rules were not proper and were not supportive of public health. On Dr. Kim's statement that Texas is helpful in guidelines, that seems radically different than what the federal judge wrote in a 20-some-odd page opinion on the 21st. At other conferences around the country, including where I've spoken, Texas is regularly pointed out as being feudal or medieval and resistant to telemedicine. And actually, was on a flight where the men who were next to me, they just want to sell pills over the web. So I would appreciate asking.
They just want to sell pills on the web? Is that
there was a quote of a board member of the Texas Medical Board. So I would like to ask the other panelists if they have a view on how Texas on telemedicine is helpful to public health and is or isn't modern or supportive compared to
Right.
other states, because it would seem to be the comment that Texas is supportive is contrary to the most recent public data.
So this is the challenge. I mean, this is sort of the Marks versus Kim undercard fight
All
that we
right.
saw earlier. Does anybody want to get into this conversation about whether we're doing enough to promote the opportunity, the any and all strategy on... anybody want to jump? Dr. Macclements?
So you asked if I had a magic wand.
Yeah.
So there are some phenomenal ideas taking place within the think tank in the medical school that I'm in, part of which is the discussion about telemedicine. And if I had a magic wand and we could just wave that wand and put these innovative ideas in place and make them standard, would be fantastic.
What's preventing that?
Well, the historical, let me back up by saying I'm not sure yet because they haven't rolled out. But historically what happens, as to your point, is we're very good in medicine of identifying how one gets reimbursed to support your day-to-day activities. One of the opportunities that I had looked into when I was in East Texas for 20 years is that, because let me tell a little story, is that I was leaving Carthage one day and I was watching a lady push a pram with her husband down the road, and she looked about 8 months pregnant. And I was acutely aware of having just been in the community providing a medical education opportunities for physicians in that environment, when a nurse practitioner had come up to me and begged if I could find any residents who could come down to the community and help her, and the local obstetrician gynecologist had just closed her practice. And as I was driving out of town and I saw this young family, my first thought is, where is she going to deliver that child in the next few weeks? Now, you can't do telemedicine obstetrics care.
Right, telemedicine may do a lot.
But that's one thing, right.
I'm not sure you're going to be able to deliver the baby through telehealth.
Yes.
Right.
You could talk someone through it.
Correct. But my point simply being that so there was awareness that in East Texas, for instance, which I understand is worst demographics in the Valley right now in terms of healthcare, that that telemedicine is a wonderful opportunity. For instance, with teachers in schools, if their child gets sick, they have to take off work and go home, take their child to maybe another city, and then the classroom suffers. There's an opportunity with telemedicine, for instance, that a local primary care physician in another center can communicate with the school nurse and find out what's going on with the child and take care of it in that kind of environment. The challenge was, though, to your question about bandwidth and was the financial support of this. Now, this has been rolled out, I understand, in communities in Georgia and extremely successfully. But trying to find the resource initially to do the stand-up and to see that this is feasible and get it rolled out in the time that I was working on this was challenging. But certainly, if we had our magic wand, absolutely it could be done.
Right. I mean, you would, it sounds to me from what you said earlier, Ms. Marks, that you and the questioner's perspective on this are more aligned.
Yes.
You believe that there's more that the state could be doing?
Yes.
Whether or not you'd use medieval as the way to describe Texas, right?
It's the Texas Medical Board that has imposed the restrictions, and many characterize the restrictions as an income protection.
Dr. Kim, it's now 1 on 2.
I want to be incredibly clear. I count Ms. Marks in my foxhole. I want to help exactly the patients that she's seeking to help.
Right.
And to the questioner's point, I preface this by saying that I'm probably risking subpoena at this point by saying this in a public forum. But what it boils down to, all of this just unfortunately tragic waste, in my opinion, of resources and time and legal fees around this lawsuit, surrounds one question, and that is, how do you do telehealth? The Texas Medical Board is very clear, as is most jurisdictions across our nation, that telehealth requires a multimodal communication system. That is a kind of a techie way of saying, how many people in the room, by show of hands, would be okay with this encounter? Let's assume that you're in a clinic room. Mr. Smith, hey, this is Dr. Kim. Why don't you tell me what's going on? Okay. All right. Well, why don't you take this and come back in 6 months and walk away? Is that encounter as a sort of a that's an example of a mono sort of modal communication thing? Or just as easily, you're having a problem, why don't you just snap a picture and send it to me, and I'll just go ahead and send you a prescription. There has to be a line in the sand drawn. Now, one day we might be able to do this with robots and drones and what have you, and delivering babies, but that day is not today. I am very confident on how I'm able to expand my footprint in reaching the vulnerable populations that desperately need this care. And that is what the Texas Medical Board is seeking to do. I'm trying very hard not to get into the details of how this is happening, but I can assure you that so long as you're in agreement with this idea that the therapeutic relationship, and I don't care if you're a physician or a nurse practitioner, being able to connect to your patient and maintain a relationship, whether it's conventionally or via telehealth, is an important sort of bedrock upon which we build our system.
Quickly, and then I want to go to this question.
And so, in also defense of my colleague, as an educator, I think I'm sort of Switzerland in this discussion. And by that I mean, as you know, when I served on the as the chair of the Physician Distribution and Healthcare Access, where our simple role was to educate, this whole discussion of telemedicine came up, and I want the public to be aware of this, is that the discussion that came out of our subcommittee to the Texas Medical Board was simply to the point that if we do telemedicine, we want to do it correctly. So there was a lot of discussion about the fact that we had telemedicine perhaps occurring across state lines, and then the question for us as physicians was, well, who is ensuring the credibility of the physician out of state? How do you know that who's taking care of your patient in the state of Texas is actually has the competency to do so? And it's if I had a magic wand today, we'd roll it out, but it is a complicated issue.
Sir.
First of all, thank you for the great open discussion. It's been great listening to you. The question I have relates to access, but from the patient point of view and cost. So one of the barriers is the cost of healthcare, why patients don't access healthcare.
Right.
So you have patients who are having to choose between utilities and healthcare, or because of medical bills are going bankrupt, or all these different issues. So what are some of the things that you know of that are going on in regards to price transparency, and the deductible costs and all these types of things? Obviously, some of that's at the federal level. So,
Dr. Ho, talk about the economics of healthcare at the moment and the degree to which that bucket of issues is part of this conversation.
Yeah, I couldn't agree with the questioner more. I think, the things we work on at the Baker Institute, I think the reason why we have an access problem is because healthcare is too expensive, and that therefore drives up premiums. And I think the one thing missing from the Affordable Care Act, which should have been there, was price transparency. So, for example, some of the things we're working on in terms of freestanding emergency departments, patients walk into these and they think they're just like an urgent care center and they don't know the price. And then they walk out and discover it's not part of network, and suddenly they have a $1,500 bill they have to pay out of pocket. So the last legislative session, there was a bill that was introduced that would require these facilities to post their prices. It passed, but it got watered down. And so now the law is only that they have to post, we're an emergency room, we can charge you a facility fee, but they don't say what the facility fee is. So we need more information on prices to deal with these issues. It's still not going to solve all the problem. There's lots of things we didn't discuss today about how Medicare is really trying to move towards value-based performance. There was an allusion to that. We need to do a lot of things. We need to do about 30 or 40 different things to change the way we do reimbursement to try and slow down the growth in healthcare costs so more people can get access to care.
Anybody else on the question of economics?
Yeah, and that's a great question. So, as a practicing physician and as an educator, we are incredibly sensitive to the amount of waste that occurs in healthcare, as well as the fact that, with the Saving 100,000 Lives campaign, etc. And my wife just recently sent me a quote that apparently medication errors are responsible to three or four in the country in terms of killing patients or killing people. So we are incredibly sensitive that what we need to do is ensure that we have a value-based healthcare, but that is not purely financial. That also is that we're delivering quality care that is what the patient wants and needs. To that end, a number of educators, thinkers are coming together right now to make that occur. Within graduate medical education, for instance, there is a requirement that we undergo what's called a clinical learning environmental review. And our accreditation board comes into the hospital environment to see that our residents are being trained in these value-based healthcare principles, quality improvement, patient safety. with the hope that what it'll also do is drive down
Drive down
healthcare
the costs.
Yes.
Indeed. That's it. Well, I'm told we're out of time. Please join me in thanking our great panelists, Vivian Ho, Thomas Kim, Jonathan Macclements, and Elena Marks. Thank you all for coming. We appreciate seeing you, and we hope to see you again. Thanks very much.